Good morning, good afternoon, and good evening to one and all. I welcome you all to today's ISAM-NExT and NECPAM joint webinar. As we all know that ISAM-NExT and NECPAM together conducts webinars once in 6 months since 2021. And we have been grateful to all the participants, the speakers and the chairpersons, and to the ISAM-NExT board, the NECPAM board, and also the ISAM-NExT and NECPAM members for having been able to continue this webinar on a regular basis. Today's topic is gender and diversity in addiction medicine. So there are certain housekeeping rules I would want the audience to follow. The webinar is being video recorded and also will be telecasted live on ISAM-NExT YouTube channel. So you can keep video off if you do not want your video to be recorded or be in the social media. Make sure you are on mute during the talks and use the chat box to post your questions and comments and raise your hand for the question answer at the end of the webinar. So this is the webinar agenda. After the introduction of the webinar series and the housekeeping rules, I'll be introducing the chairpersons. Then the introduction of the webinar topic and the introduction of speakers will be done by our chairpersons, Dr. Abhishek Ghosh and Dr. Lisa Janat. And then our three speakers will be presenting their topic on the theme of the webinar. Then there will be the question answer sessions. And then the chairs of ISAM-NExT and NECPAM will be presenting the updates about the committees with the ISAM-NExT committee and NECPAM society. And then there will be summary and closure of webinar. So without further delay, I'll be just introducing the chairperson. The first chairperson is Dr. Abhishek Ghosh, who is an associate professor and at Postgraduate Institute of Medical Education and Research at Chandigarh in India. And he has done MD in psychiatry and DM in addiction psychiatry. Some of his major achievements includes international consultant for the UNODC, worked with the ADAB unit at WHO, on psychosocial treatment for adults with alcohol dependence. And he has also developed guidelines for the treatment of substance use disorder in pregnancy and updated the health and social effects of non-medical cannabis use. He is also an ISAM fellow and member of the Global Expert Network. Dr. Lisa Danat, the other chairperson, she is an addiction psychiatrist and senior lecturer at Groote Schuur Hospital and the University of Cape Town, and she has multiple academic qualifications to her credit. I now would like to hand it over to the chairpersons.
Thank you, Preeti. Welcome, everybody. So today's webinar is titled Gender and Diversity Issues in Addiction Medicine. This is an important topic because although men have more substance use disorders than women who use substances, women are far more likely to face far-reaching negative sequelae, and traditional treatments don't cover these women. It is important, therefore, to develop education, training, and services to address these discrepancies. And this is the purpose of today's webinar, to start our training. I'm going to hand over to my co-chair, Dr. Ghosh, to introduce our first speaker. Thank you very much.
Thanks very much, Lisa, and thanks to ISAM-NExT and to NECPAM. Thanks to Preeti for her kind introduction. So the first speaker for today's webinar is Dr. Francina Fonseca. Dr. Francina is an addiction psychiatrist. She is the head of the addiction section in Hospital del Mar, Barcelona, Spain. She is also an associate professor in medicine and life sciences at the University Pompeu Fabra. She is primarily a clinician, but also an avid researcher, and her areas of interest are sex and gender perspectives in mental health and addictive disorders. So this webinar topic directly is aligned to her research and clinical interest. Dr. Francina is going to talk about gender and sex differences in addictive disorders very nicely and wisely. She has combined two terms, sex and gender. Sex, which is a biological and physiological phenomenon, whereas gender is a socio-political cultural construct. So we are all expecting kind of a presentation from Dr. Francina, where she is going to talk about how gender and sex both together influence the drug use pattern, the drug and alcohol use disorder development, the consequences, differential consequences of drug and alcohol use in men and women, the different and unique psychosocial needs and concerns for women. But we also must recognize the fact that gender and sex are not binary entities. There are LGBTQIA plus population, and we must also recognize the special need for this population. I'm sure Dr. Francina is going to talk a little bit about that as well. So without further ado, I invite Dr. Francina to present and deliver. Thank you.
Thank you very much. Thank you very much for your kind presentation. I will share my screen. I hope you can see. Oops. Can you see the presentation correctly?
Yeah, we can.
Yes, yes.
Okay, thank you. Thank you very much to invite me to present. As I said, as my colleague said, I am very interested in sex and gender differences in addictive disorders. The content of this presentation, I will start with basic concepts to understand, because sometimes we speak about sex and gender and we don't make differences, and it's important to conceptualize this correctly. I will speak a little bit about the prevalences and differences by gender and how can we explain these differences in addictive disorder. I will talk more in neurobiology and sex differences than in gender differences. It could be a very big topic to speak about, and I say some take-home messages. I will try. I will not cover all the information because there is a lot, but I will try to make a comprehensive presentation. So first, when we speak about sex and when we speak about gender, what are we talking about? Sex is a biological construct, and it's based in chromosome configuration, hormones, and physiology, neurophysiology. And it's related with sexual individuals, and usually is assigned at birth, usually by the differences in external genitals, and also sometimes with a chromosomic study. And on the other hand, gender is a social and a cultural construct, and it's a personal perception. It's not assigned externally, but it's the personal understanding of oneself gender. And it's implicated and involved in human beings' interaction, and it gives different access to resources, benefits, and implies some hierarchy. There are some genders that are on the top on the hierarchy, and other gender that are in the bottom of this hierarchy. Sex is in general, is a dichotomic variable. I put a mark this because there are some intersexual situations we studied in medicine, but usually sex is related with being a man or being a woman, and it's based on the chromosomal differences. But there are some intersexual states that can be studied. But gender, in the contrary, is a continuous variable, and it's defined by characteristics that could be implied behavior, psychological responses, culture, politics, and the society gives some different roles and different behaviors and implies differences, and it's expressed in a continuum, in a variable that could be dichotomic or categorical. And when we speak about gender identity, it's important to notice that every person has a personal perception about their gender identity at a social and a psychological level. And it's a personal experience of being a woman or being a male or being other genders. Usually the most common is that gender is concordant with the biological sex, but it could be dissonant, and it's important for us when we speak with patients or make some research to ask about the gender, about the sex, and also about the gender, because are differences. And when we speak about the prevalences, I will make this as an example. This is a review of prevalences of some psychiatric mental health disorder in persons that use drugs. The graphic in the left, I don't know if you see the pointer, but it's a general population sample of 5,000 approximately persons. And we see that the prevalences of mood disorder, major depression, anxiety disorder, PTSD, and panic disorder in general population, as we know, is more prevalent in females than in males. But when we look at the right side of the graphic and we look at the people who use drugs, this is a sample of 629 patients, some patients in outpatient settings, some patients in inpatient settings. We see that in general, these mental health disorders are more common in people who use drugs. But look at the right, and you see that females that use drugs have a very high prevalence of mood disorders, depression disorder, anxiety, post-traumatic stress disorder, and panic disorder. More than male and more than female in general population, more than expected in the general population. Also, I want to remark that these differences also are observed when we look at the psychiatric drugs prescribed. But it's more than expected this, because we see that the psychiatric drugs are more prescribed in women than in men, and it's expected because we see that there is more prevalence in women than in men. But can you see that 85% of psychiatric drugs are prescribed in women and 15% in male, more than the differences in prevalence. This is related with gender, not with sex, because there is a kind of psychiatrization. I maybe make a neologism or I have make a new word, but it's related with these differences in hierarchy and the social expectancies that are made for women. I present you some examples. There is some advertisement from 1950, 1960 about drugs prescribed for women, and you can see what was the expectations for women. Women need to take methamphetamines to work harder. They need to be slim and to be nice and to be attractive, and they have to take amphetamines to lose weight. And they have to be relaxed and to feel less anxious, because they have to work at work and at home, and to clean and to iron, and they need oxazepam and benzodiazepines and barbiturates to stay quiet. These are the expectation. And can you see what is the social idea of the role of women in the society? So how can we explain these differences and this what we see in the society and the prevalences in addictive disorder and other mental health disorders? For instance, the first thing that we have to take into account is that in addictive disorder there is a telescoping effect, and we observe an accelerated progression from substance use initiation to addiction development and first admission to treatment in women. Women develop more quickly an addictive disorder than in men when we start taking use drugs. There could be pharmacokinetic differences. For example, we see in the toxicity of alcohol, there is a first pass metabolism. Women have higher plasma concentration of alcohol. We also have low concentration of alcohol dehydrogenase in the stomach, and we get more higher concentration of alcohol in the body and in the blood. So it's more toxic for women. Also, we see that women have higher and quicker concentration of nicotine when we smoke. And we will present later different responses to cocaine depending on the menstrual phase. And this is related with sex differences. There also are differences in gender. There are more barriers for women to access to treatment for addiction. There are more stigma in women than in men when they use drugs. We also have this maternal role to accomplish, and this is important, and this is very conditioning for women. In pregnancy, there are the fear to lose the children custody, and also women, we suffer from family and environmental hostility towards these women that are using drugs. We also receive more intimate partner violence. They usually have more partners using drugs, and women are in social disadvantage. And this is a limitation and barriers to achieve treatment for addiction. Also, apart from these barriers related with social conditionings, there are some neurobiological differences. I will speak about 3 systems. There are more of them. I see that it could be a very wide field to explain. But I will talk about the hypothalamus pituitary adrenal axis, which is involved in the control of stress and the responses to stress. And we can see in this study from 2017 that we see differences in the cortisol response in females compared with males after a challenge and a stress challenge, the trial stress test. After a stress challenge in women with the major depression disorder, clinically active, we see that the response to cortisol is lower in women, in patients, in women with depression compared with women controlled without depression. As we see a different response in males, and you see that cortisol in males with depressive disorder after a stress challenge is higher than for control. We don't see these differences when we look at female with depression but in remission, and we don't see these differences in males in depression with in remission. We cannot observe these differences in anxiety disorder or in schizophrenia between male and woman. We don't see these differences in females, but we see a trend in males with schizophrenia with a lower response to stress. We can conclude with this that the response to stress in women with depression that is different than in male with depression. So the response to stress, how to cope with stress is different in male than in females. You also see that the cortisol level has been different in a sample of people that has been admitted in a substance use disorder resource for a detoxification in a detoxification unit, and then the time that people are admitted and the levels of cortisol are different in women than in male admitted. So a stressful event that is an admission to a detoxification unit could be lived in a different way in male than in women. Also, stress is related with, we know that stress and life events are related with substance abuse in the adulthood, and we see that childhood trauma is associated with less reactivity of this hypothalamus pituitary axis, and this low reactivity has been associated with more prevalence of obesity, addictive disorders, and depression. So we have women with experience a lot of stressful events in the childhood and in the adolescence, a different response to this stress, and a more probability to experiment different illnesses, addictive disorder, and depression. Also, sexual hormones are important. This is just a review of the differences in the estradiol and the levels of estradiol and progesterone during the human menstrual cycle, and we see that estradiol increases during the follicular phase. There is a peak in the periovulatory moment, and then there is a decrease and an increase, a little increase during the luteal phase. And in the other side, progesterone is very low during the follicular and periovulatory phase, and later on it's increasing in a peak. And this can condition and implies differences in response to drugs, because sexual hormones are involved in the circuitry of reward, in the reward. We know that the progesterone and estradiol affect differently in the centers of reward. For example, in the accumbens and amygdal function, in the dopamine activity, and also in the hippocampal functional activity. We know that in females, ovarian hormones induce changes in dopaminergic signaling. Estradiol and progesterone affect the receptor binding with the striatum, and also estradiol regulates dopamine-mediated motivate behaviors. So women has an increased sensitivity to rewarding stimuli than males, and also there is a greater risk for addictive disorders, and it could explain this telescoping effect, this more sensitivity to the rewarding effects mediated by estradiol. And this is, for example, this is a very classic study, but it's very nice. we see that comparative with females in the follicular phase and females in the luteal phase, and responses to cocaine. And we see that for feeling high, for feeling stimulated, and the desire for cocaine, male and females in the follicular phase, the response is similar. And in the luteal phase, when progesterone is high, we see a low response of feeling high, of feeling stimulated, and the desire of cocaine. On the other side, the feeling of paranoia, it's very low for women compared to male, and this is probably the protective effect of estrogens for psychotic symptoms and psychotic disorders that we can see in women with previous to the menopause. And also we see that in the postmenopausal women, as the association with lower levels of progesterone are associated with higher problems related with craving and response to alcohol, comparing women in postmenopausal phase and women, for example, women and men in the different phases, in the premenopausal phase and the postmenopausal status in women. And the responses of craving are different. Sexual hormones are usually protective to the use of some drugs. Also, in this other study, they see the effects of daily smoke. They control the number of cigarettes and the reinforcement made by nicotine and cigarettes in women in different phases of the hormone phase. And they say that progesterone elevated levels lessen the propensity to smoke in women. And in the other side, the estrogen levels influence the subjective experience of smoking and increment the reward by smoking. And this is confirmed the results seen in the previous study, in the previous slide. This has been used to try to use sexual hormones or to use progesterone to treat addiction. And there are some studies made in postpartum women with cocaine use disorder, and they were treated with progesterone, and the relapse response was lower in the women, in the group of women treated with progesterone compared to placebo. Similar responses have been seen when they treat postpartum women treated for nicotine use disorder. Here, what was studied was abstinence, and patients maintained with treated with progesterone maintained at least during some weeks, postpartum weeks, more abstinence than women treated with placebo. This has not been confirmed in a later study in women without, not in the postpartum phase, in a general population, general woman population, treated for cocaine use disorder, and they tried to compare progesterone and placebo, and they said no differences in the retention in treatment, in days in treatment, and there are no also differences in the abstinence rates. But can you see that the groups were very small? 10 women in the placebo group, 11 women in the progesterone group, and it was very difficult to have conclusions, statistical and conclusions that were solid. So there is a field to study more in this way. Finally, I will talk a little bit about oxytocin. It's involved in modulated fear and stress responses, and also oxytocin levels have been involved in stress responses after a trauma. Oxytocin is involved in different phases of addictive disorder, in early drug experiences, reducing the reinforcing effects of the drug and novelty seeking. It also involved in progression to addiction because it's involved in lower dependence development, tolerance, and withdrawal symptoms because it reduces stress, and also in drug cessation and relapse because it can impact on drug prime and the impact of exposure to cues in relapse prevention. Oxytocin has been also evaluated in combination with sexual hormones and ovarian hormones and stress reactivity and cortisol response, and have differential effects in men and women with cocaine use disorder. And it confirms that women are at greater risk for relapse in response to stressors in the relationship with oxytocin, cortisol, and sexual hormones. you can see the differences in the responses by gender, and female have more risk to relapse than males compared with comparing females with males. And sorry, I don't know if I had more time than needed. I just want to finish my presentation with some take-home messages. First, there is a high prevalence of dual diagnosis in women, mainly affective disorder, depressive disorder, anxiety disorder, and post-traumatic stress disorder. There are an involvement of different hormone systems, mainly cortisol and the hypothalamus pituitary adrenal system, sexual hormones, and oxytocin. But it's important also to avoid reductionism. There is a combination of effect of sexual, psychological, and environmental factor, and it's essential to have a gender perspective in research, in assessment, and treatment, and to offer different treatments or to adapt our treatment systems to female and to male to treat different necessities and to different responses to stress and risk for relapse. Thank you very much for your attention. This is an image from my hospital, Hospital del Mar in Barcelona, very nice views from my center of work. And I give the floor to my colleagues. Thank you very much.
Thank you very much, Francina, for this excellent presentation and overview. You have covered a very complex area comprehensively in a short span of time. You have covered the biological aspects, the psychosocial aspect, the gender and the sexual, as you have promised. And I'm sure that people will be interested in asking questions, but they can pose their questions in the Q&A or in the chat box, and we'll take up the questions at the end of the all three presentations. Now I'll hand over it to Lisa, my co-chairperson. Yeah, Lisa.
Thanks. Thanks again, Francina. So our second speaker is Dr. Amanda Lieberman. She is a global health equity scholar from Yale University School of Medicine, and she's an MD MHS candidate for 24, and her major achievement is the Fulbright Award. Dr. Lieberman is going to be speaking to us about the legislative barriers to opioid use disorder treatment in Central Asia. Thank you very much, Amanda.
Hello, can everybody see these slides okay? Okay, great. So first I should clarify, I am not yet Dr. Lieberman. I will be next year. So I'm currently a MD MHS candidate from Yale, and I am based in Central Asia, where I do research into barriers that people face to methadone treatment. Okay. So a little bit about what we are going to speak about today. Let's see if I can find this. Okay, so first, what is methadone maintenance? Why do we use it? That should be familiar to most of you. Second, we'll be comparing the legislation, methadone legislation in 3 countries, Kazakhstan, the Kyrgyz Republic, and Tajikistan. And then finally, we'll be talking about what these barriers mean for HIV prevention in Central Asia. Okay. Oops. All right, so first, this should just be review for most of you, but a quick guide for what is methadone. So methadone is a synthetic opioid agonist that is used to treat opioid use disorder. And the goal of methadone treatment is to prevent transmission of HIV and other infections among people who inject drugs, and to reduce the risk of fatal overdose among people who inject drugs. And it is often a long-term treatment, sometimes even a lifetime treatment. So it's not we used to previously believe that we could just gradually help people quit, so to speak, methadone, and then later research has shown that that actually is not as effective, and people often relapse when that occurs. So a little bit about Central Asia. Up to 60% of the cumulative HIV cases in all of Central Asia have been among people who inject drugs. So methadone maintenance therapy is regular administration of methadone that relieves withdrawal syndrome and reduces cravings associated with opioid use disorder. This is a quote from one of our patients in Tajikistan. Now I am leading a normal life. My wife and my 4 children are back with me. So this treatment has the power to really change lives for people here who are struggling with opioid use disorder. So now more onto the legislation side of things. Just to clarify for everybody what this region looks like. So Russia is up here, of course, in the north, and Russia has an outsized influence in the region. All of these countries are part of the former Soviet Union, and the collapse of the Soviet Union really played a major historical role in the spread of the opioid epidemic. There is a route known as the heroin highway that takes heroin from Afghanistan to China and to Europe. And it goes through these countries. So there is a lot of heroin that flows through all 3 countries, Tajikistan, Kyrgyzstan, or the Kyrgyz Republic, and Kazakhstan. And then the turbulence that occurred during this historical time really affected. So there was increased freedoms, but also there were, for example, a lack of food available in grocery stores. And that to this day still influenced the very high rate of the opioid epidemic that occurred here. Even to this day, there's very high mobility in the region. So anybody who has a passport from one of these countries can easily travel to any of the other countries. And a lot of people will actually go to work in Russia where methadone is prohibited. There's also a lot of stigma and discrimination against people who use drugs, and there is a lot of infrastructure-based challenges in terms of methadone access. This also affects heterosexual partners of people who inject drugs. As you can see, 6.4% of these heterosexual partners, and that does include both partners who do use drugs and partners who don't, have HIV as well. Something to emphasize is the prevalence in migrant workers. Of these, the new cases of HIV among people who inject drugs in Tajikistan, 1 in 5 are among migrant workers, but in spite of all these challenges, less than 5% of people who inject drugs in the region benefit from methadone therapy. So just to recap that, here is the coverage of opioid agonist therapy among people who inject drugs in Central Asia, and you can compare it to other countries, understanding that the recommended amount is 40% in order to achieve some of these benefits that we were talking about in terms of reducing risk of HIV spread in the population. We are well below that. You can see over here, Kazakhstan, Kyrgyzstan, and Tajikistan, and all have extremely low rates of opiate agonist therapy or methadone coverage, since these countries only have methadone. So a brief timeline. Kyrgyzstan opened its first site in 2001, Kazakhstan followed in 2008, and Tajikistan followed in 2010. Up to today, Russia continues to ban all medication-based therapy for opioid use disorder and remains heavily influential in the region. Since a lot of people are migrant workers to the region, if they are using methadone therapy, they lose access when they arrive in Russia. Okay, so just as a quick summary of the legislation, in all 3 countries, methadone is legal. In Kazakhstan, it's very restricted. In Kyrgyzstan, the program itself is under threat. And in Tajikistan, it's very hard to access. Okay, so first, Kazakhstan, some of the legal restrictions involved. You are required to join a national registry of addicts, as well as a registry of people who are on the methadone program when you enter the methadone program. This is comparable to, for example, in the United States, there's a sex offender registry. So this registry actually can affect job opportunities. It affects people's access to driving licenses. So it has really far-reaching consequences. Additionally, people in the program are required to undergo regular substance testing. They have daily in-clinic receipt under medical supervision. So they cannot take any methadone home. they must be at their specific clinic every single day. And if you don't live in one of the major cities, this can be a real barrier for access. As you can see, this program opened in 2008, and up to today, less than 1% of people who inject drugs in Kazakhstan have currently participate in the methadone treatment program. In Kyrgyzstan, this has the most progressive laws of these three countries, given that methadone is not considered a dangerous narcotic drug the way it is in Kazakhstan. There is still a requirement for registration as described in Kazakhstan, but there is currently a working group that is working to remove that requirement. So there is hope for the future that that will no longer exist. And patients can actually receive take-home dosing if certain criteria are met. However, in 2011, a documentary movie came out during which people described methadone as a trap, as a hole that they fell into that they could not climb out of. And since that movie, there have been multiple calls in Parliament to close the program completely, and the program remains continuously under threat. As of right now, in spite of having been open for over 20 years, only about 4% of people who inject drugs participate in this program. In Tajikistan, methadone is also legal, but it is unavailable for most individuals. It's on a list of essential medications in the country. However, it is also on a list of dangerous narcotics in the country. So it's on actually both lists. Now, what this dangerous narcotics list means is that there's very limited options for transportation of methadone. For example, it must be transported with armed guard accompaniment. There's a lot of lack of political support in Tajikistan for the program, especially due to religious and cultural reasons. There's a strong reliance on abstinence-based rehabilitation programs, as applies actually to all three countries. There's very limited funding or infrastructure for transportation of methadone to different parts of the country. Methadone clinics are not integrated with other healthcare services, so people have to go to their methadone clinic and then, for example, to their HIV clinic or to their hepatitis C clinic. And then there's very low awareness that the methadone program even exists. Clients report police harassment. Like in Kazakhstan, there is no take-home dosing, required registry participation. And in spite of having opened in 2010, this program is still formally a pilot program. As of currently, there are 2.9% of people who inject drugs participate in this program. Okay, so just to tie it all together, some common barriers across these three countries are requiring citizens to register with the government as being a drug addict. And this has long-reaching consequences. Now, normally in our field, I would actually say people with substance use disorder, but here the word that they actually use is more close to addict. And a lot of workplaces will require certifications from a doctor that you are not on this registry if you are to receive a job. One of my focus group participants even told us that he couldn't get a job at the zoo feeding the animals because once he was on this registry, even that was barred to him. All three countries currently struggle with funding. All three are funded by international donors and are struggling to transition to state-based funding. There is limited access at all sites. Daily attendance requirements in both Kazakhstan and Tajikistan, and it is difficult but possible to get take-home dosing in Kyrgyzstan, or the Kyrgyz Republic. Cultural attitudes toward methadone in all three countries are largely negative. Most people will say, oh, that person is just switching from one addiction to another. So some strengths of the program. The programs have expanded over time. And there are authorized bodies and clinical protocols in place that could promote further expansion. Some weaknesses are some of these structural challenges and funding that we've talked about. Methadone is seen as a method of HIV prevention and not opioid use disorder treatment. So why does that matter? Well, if people already have HIV, it can be harder to join certain methadone programs. Doctors usually have full control over the program of who can or cannot join, and often they will have very, very restrictive criteria of who can join. So some opportunities for the future. These programs have the potential to really have an impact on HIV incidence in this region. And if these could be integrated more into the healthcare system, this could potentially also increase access to treatment for infections that are common among this population, like hepatitis C or HIV. However, there is the possibility of program closure really at any moment in all 3 countries, and participants in the programs face ongoing harassment, discrimination, and stigma. So this is my contact information. Special thanks to my research team here in Kazakhstan and back in the US. Special thanks to my funding organizations. And here are my sources. Thank you so much for listening.
Thank you so much, Amanda. I'm not going to apologize for promoting you to doctor. You are almost there. I'm very impressed with such a comprehensive talk and research project coming from a medical student. I am, like Abhishek said, we will have time for questions at the end of our sessions. So I'm going to hand over to Abhishek to introduce our final speaker.
Thank you, Lisa. I guess we have kind of a roller coaster ride today. We started from Europe, Spain, Barcelona, went on to Central Asia. Now we are going to Southeastern Africa, Malawi. And there we have Dr. Beatrice Lydia Matanji. She is a public health physician. She is the medical director for Partners in Health in Malawi. She is an MD doctor. She has also done MSc in epidemiology and PhD in global health implementation. She has pioneered the establishment of National Non-Communicable Diseases and Mental Health Program in Malawi from 2012 and 2017. After that, she led the development of the first national alcohol policy for Malawi against alcohol industry interference that was launched in 2017. And she has been very passionate in early identification of alcohol use disorder. So she has decided to translate and validate alcohol use disorder identification tests in the Malawian context. So she has been in the field for quite some time. And we today is going to hear from her, her experience of an outpatient department of Malawi, the people who were seeking treatment for alcohol use disorder, and how gender and societal roles are influencing the alcohol risk there in Malawi. So I invite Dr. Beatrice to deliver the presentation. Over to you, Dr. Beatrice.
Oh, sorry, I was still on mute. Hello, can everyone hear me?
Yes, we can hear you, Dr. Beatrice.
Okay, I'm trying to put my video on, but apparently, I think my network is not very stable. So if you are okay, I could continue with without the video.
Yes, please, Beatrice, continue.
Okay. So thank you very much, the co-chairs of this webinar, and thank you everyone who has joined to listen to these presentations. I would like to take a few minutes to talk with you on the topic around gender differences on the prevalence of alcohol use disorders among OPD attendants in Malawi. And I will use not only my work, but also previous work done by others on what are the social norms in Malawi, and also what I saw as the alcohol use disorder preferences. So, sorry. So I'll go through the introduction, and as I said, I'll end with the social norms. So that's Malawi. For some of you that may not have an idea, or you have ideas, but maybe you can't really locate Malawi in your head. Malawi is in the southern part of Africa, and we're almost engulfed by Mozambique because the western part, eastern part, and southern parts are all covered by Mozambique, but also bordered by Zambia and a bit of Tanzania. So the population, the estimated population is 19.3 million, over 50% are females, and we have under 5 children also over 50%, and 84% of the population is rural. Over 20% of the population lives outside the acceptable distance within a primary health facility, and therefore preventive measures are more important for health service delivery, so that we don't have a lot of people needing, at the end of the health status and needing health services. So what I'm talking about today is more on the preventive side. The life expectancy is at 63.7 years. It has been improved quite a lot since ARVs came, because the HIV burden is also quite high for Malawi. It is one of the poorest countries, with the GDP of just 526, that's by 2020. And within the sub-Saharan African countries, we know that alcohol is mainly brewed at home, and it's brewed by women, and therefore contributing to the gender differences as well. So harmful use of alcohol is one of the key risk factors for development of non-communicable diseases and mental health conditions. As introduced already, for Malawi, our NCDs and mental health program only recently started in 2011, 2012, and I was part of the team that established the program. And for me, I'm a general physician, I'm not a psychiatrist, but for me to go into the interest for this topic is because we needed to look at what are the comorbidities for general NCDs and what are the risk factors. And alcohol use our harmful use of alcohol is one of them. So Malawi, like many sub-Saharan countries, has high alcohol abstinence rates. It is good to note that alcohol consumption rates are only around 27% for males and only 1.6% for females. Which means that women are not drinking much, and generally the population is not drinking much. But unfortunately, the total per capita consumption among drinkers is estimated at 15.5 liters of pure alcohol, which is around 18.9 for males, 7.2 liters for females in a whole year, which means that the fewer people that do drink are drinking dangerously. Like the high abstention rate coupled with high total consumption implies risky drinking behaviors. Unfortunately, our legislative and policy environment is at its infancy in terms of effective alcohol harm reduction, because in a study that we conducted and documented in 2018 on alcohol policies in Malawi, inclusion of World Health Organization-based bar interventions, we found that the national legislations and policies had inadequate inclusion of the relevant interventions for control of harmful use of alcohol. So the next step for me was to look at what is the prevalence of alcohol use disorders within the health facilities, because we know that the national alcohol policies are focused at population level, their population level interventions, but we wanted to see that now that there was not, and the policy was just coming up, not implemented that much, what is the baseline problem within the facilities? So to estimate the prevalence of alcohol use disorders among patients who were attending general outpatients, as well as NCD-focused clinics in Malawi. So currently all hospitals and these semi-secondary level facilities, even some primary facilities, are having non-communicable and mental health disease-focused clinics. And I looked at around 914 participants from 5 hospital OPDs and NCD clinics, and this was within 2017. The age range was 18 to 94 years, and alcohol use disorder that I was measuring was defined as any level of risky alcohol drinking, either hazardous, harmful, or likely dependent use, measured by an adapted and validated alcohol use disorder identification test. So through the study, another study that I did on validation of the audit, I found out that the appropriate cutoff score for Malawi is at 4. And current alcohol drinker was defined as any participant who reported consumption of any alcohol in any amount over the previous 1 year. So when I'm talking of among current drinkers, I'm talking about consumption within the past year. As part of the work to validate the tool that I used to measure the prevalence, adaptation of the drink illustrations for the audit was an important part of the work, because in Malawi, as I said, most of the alcohol is home brewed, and the international audit, or the one that is out there, the illustrations are just talking about the last part of that picture I'm showing there. So you have maybe ciders, wines, and spirits, but you have nothing that's showing what people are drinking locally, and also the alcohol concentrations, so the ABVs. So I did some study that looked at, I took samples, took them to the reference lab, we did concentrations of all the local alcohols, and although it's not absolute, because we know that like the cereal or corn-based alcohols or beers, they do ferment over time. So these were estimates, and so the audit tool that we were using for the study that I'm about to, whose results I'm about to describe, had these illustrations that were adapted based on the alcohol concentrations that were contextualized in our setting. So the first section there is looking at Malawi traditional alcohol drinks that are traditional spirits in different volumes, because we have some that are in 330 ml volumes, others in 200 ml volumes, traditional wines. So people here do make wine traditionally from different fruits, from different things. They do make wine at traditional level, and drinkers do take that. We also have corn-based or cereal-based beers, which are mostly taken in 1 liter or 1,000 ml volumes. So I did put this up for the sake of the providers when they're showing the participant or the client at the facility, what kind of alcohol do you drink? When they point at what they drink, it can be user-friendly to know what kind of percentage, the percent ABV that they're taking, and therefore how many units of alcohol, and therefore we can apply the audit without much problems. That way I can present at another time, but I just wanted to bring that to contextualize where the prevalence was coming from. So results briefly, among the 914 participants, about 46% reported lifetime alcohol drinking, but only 40% were current drinkers. And among the current drinkers, only 50 were females, so majority were males. And regardless of the alcohol consumption status, whether they were current drinkers or not, overall preference of moderate to severe alcohol use disorders based on this adapted audit that I mentioned was that 37.7, let me say 38%. But it was 73% alcohol use disorder prevalence among males and only 19% among females. And this was a statistically significant difference. Then among the current drinkers only, taking out those that had stopped. And as if you remember, I said it was both in general OPDs and NCDs clinics. So in the NCDs clinics, because of behavior modification, some, when they're told now you have diabetes, you have hypertension, they're likely to stop drinking or to modify their behaviors. So we did have people who had stopped drinking. And so among the current drinkers only, the overall prevalence was 90% of alcohol use disorders. So not many people are drinking, only 40%, but 90% of them, and as much as the 97% among males are having an alcohol use disorder, moderate to severe. And differentiating by service delivery sites, 96% of these alcohol use disorders were among general OPD current drinkers, while 77% were among the NCD clinic attendants. So in summary, the general OPDs, the outpatient departments, have more current drinkers and also more AUDs than the NCD clinics. And as I said, this could be attributable to the behavior modification that happens in an NCD-focused clinic, or in general OPD, everybody's just looking at malaria, TB, HIV, nobody's paying attention to the alcohol use disorders. Yet these people came to the OPDs just for the condition they came for, but I screened among them and found these levels of alcohol use disorders. Now moving to social norms and these gender differences. Just to recap for Those of us that may not be quite aware, norms are social by nature and can be understood as common understandings among members of a group for what is considered suitable behavior. So this is really based on what is taken and considered as the suitable behavior. And social norms teach us whether our behaviors are likely to obtain positive or negative reactions if they are endorsed or not by the people that we are with. Within the alcohol setting, alcohol norms are learned by observing and imitating significant others' behaviors and attitudes. So if someone is important to you, they're significant to you, their behavior, their attitude, and everything can modify your tendency to drinking or not, as well as through the direct consequences that we experience from these same socialization agents. So if there are any consequences, we know that the audit also measures that. It does measure the consumption itself. It measures the consequences or effects of the drinking. So the consequences that one gets from drinking, from the people that they associate with, are also part of the norms that can modify the drinking. And social acceptance of drinking behaviors varies between and within cultures based on demographic differences such as gender, age, religion, and socioeconomic status. And my focus today is the gender part of the differences. Sorry. Okay. So I was trying to progress, but the slides were not moving. I hope you can see the next slide, which is the second part of the social norms.
Yes, Beatrice. It is visible.
Okay. Okay, thank you. So in 2013, Natvig and Muntali, and this is one Malawian and one Russian author, they examined and added Malawians' alcohol use and social norms. So they looked at what are the preferences of alcohol use or rates of alcohol use, but beyond that, what are the social norms at population level among over 31,000 household heads and spouses, and within over 1,700 households. So this was a national level population study where at least one of the household heads was an alcohol user. They looked at injunctive norms that were measured as a sum score of 8 items, asking how much alcohol most people who were close and important thought was okay for one to drink in different situations. So the situations could be at home, at a party, on a street, whether you are with children or not, or with a parent or you're not. So there were different situations that were presented to the participants to look at how much alcohol most people who were close to them thought was okay in those situations. And they were responding according to the Likert scale that was presented to them. So briefly, among drinkers only, this is where they found that 27% of males were current drinkers and 1.6% were current drinkers. More of the women's variances in alcohol consumption were explained by their norms than the men's. So for men, it didn't really matter much. There was no statistical difference in what they drank versus the norms. Well, for women, their alcohol consumption rates were explained more by the norms. And specifically, drinking social norms explained about 7% for men's behaviors, while 21% for women's alcohol consumption. So we do see that there's an influence that social norms or the acceptance of drinking within the community has on how much people drink or not. And also it could explain why females are not drinking much or are not reporting much alcohol drinking in these surveys. In conclusion, alcohol use disorders are highly prevalent among health facility attendants in Malawi, both at general OPDs and also in NCD's focus clinics. And from both the previous studies as well as my own studies, females have less alcohol consumption and alcohol use disorder rates than males. And since only a small proportion of women report drinking, prevention efforts could be directed at helping the women not to start drinking by supporting their existing gender-specific descriptive drinking norms. So it looks like because of the effect or influence of the social drinking norms among women, we could keep them away from getting the alcohol use disorders more by encouraging them to stick to those norms. And women's alcohol consumption is strongly related to their perception, is also strongly related to their perception of other women's alcohol use. So apart from their own perception of what others think of them, they also get affected by the perception of how do they look at others when they're drinking. So in conclusion, social norms might be a promising pathway for further exploration for planners of alcohol harm reduction efforts. We know that in the current global and national policies, most of the effort is on mass awareness, on taxes, on drink driving controls and other population-based controls, but not so much maybe on individual or contextualized circumstances like social norms. These are the sources of my presentation today, and you're all welcome to visit Malawi someday. Thank you.
Thank you very much, Beatrice, for the excellent presentation and for the invitation to Malawi as well. Looks like an excellent country. I heard that there is a freshwater lake in Malawi, which is very famous, and there is a national park as well. So,
sure.
Well, that was a very nice presentation. You not only talked about the prevalence of AUD in general OPD clinic, and it also talked about how the social norms influence the women particularly more than men, and how the social norm can be used for prevention of alcohol use and alcohol use disorder. Thank you very much, Petra. Well, now all the presentations are over, and thanks to all the speakers. Lisa, I hand it over to you for any question chat box. Start.
Cool. Thanks everyone for your excellent talks. We're going to open up for questions. There's two ways of doing this. You can put your question in the chat and Abhishek or I will read it aloud to the speakers, or you can raise your hand if you have a question. You're welcome to switch your cameras on, all the participants at the moment. So the first question I'm seeing in the chat is from Dr. Morgan to Amanda. She's asking, some countries that have banned methadone defend their stance by saying that the ongoing opioid in the US proves that methadone substitution doesn't work. What are your thoughts on this, Amanda?
Oh, I actually typed my answer, so I'll just read it out loud, but
cool.
Or like summarize.
But everyone.
Yeah, I was saying that people do often reference other countries, but the US isn't as much of the example just because Uzbekistan is so much here more prominent. Uzbekistan is a neighboring country that tried methadone as a pilot program like all of these countries tried, and then they closed their program. And so people will say, oh, look how it failed in Uzbekistan. Another example that they actually use is Ukraine. There's a common myth here, and it was actually perpetuated by a member of parliament in Kazakhstan, that the Orange Revolution in Ukraine was caused by methadone. They're called methadonists here, like people who use methadone, that they were denied their methadone and that caused the revolution, which if you look at the timeline, that's actually historically completely impossible because the program started around almost exactly the same time. So there actually were no people in the program at the time of the revolution, but like the historical facts don't matter to people in this. It's just, it's a talking point. So in response to these kind of things, I usually will turn to more, at least here, because I work here in Kazakhstan and I do interviews and focus groups with people who inject drugs on the methadone and not on the methadone program, and then interviews with a lot of these doctors. So I find that the personal examples tend to connect with people more than these overarching statistics. So like I gave the example of one doctor who talked about how seeing a mother who was now buying bread for her child every day, like that for him was like a really changing moment, because before she had not been really able to provide for her child. And I find that like often when we connect it to family, that really resonates with people more. But then I was saying that one thing that is more similar to this, in the US, there's this opioid epidemic that's spreading like crazy and you guys have methadone type of thing, is that sometimes people will say things like, I don't want to be standing and advertising the program because then all of the teenagers will start using because they will find out that there is a treatment. And we don't want them to know that drug treatment exists, because if they know that drug treatment exists, then they will all go use drugs. And this, for me, the only way that I've found that kind of works to respond to it is to really go on the HIV route, because there is more recognition nowadays that sexual education and prevention education does prevent HIV transmission. And that there was a lot of pushback in a lot of these countries for a long time on any type of education like that. And the HIV community was really able to like expand minds about that, about like, okay, when you teach people how to prevent HIV, it's not that they all start having unprotected sex because now they know that sex exists. No, actually, it does reduce transmission. So going that route and explaining like, this is what we've seen with HIV, maybe this could be something here in Kazakhstan. Although a lot of my work is more based on actually like just learning people's opinions than on changing minds as much. So it's really only like after the interview has concluded that sometimes I'll like add these little things.
Can I respond?
Yeah, of course.
All right. I thank you so much for engaging me, Amanda. I was really just playing devil's advocate there because like you, I'm also very interested in the topic of methadone and legislative barriers. And yeah, this, I think, you know, there are some countries that use these kind of arguments or debates when it comes to methadone. I wanted to add to the legislative barriers faced and talk about the South African context, because the majority of people in the part of South Africa that I'm from that use heroin actually smoke heroin in combination with cannabis. And there isn't a national rollout of methadone. So there's a few non-governmental organizations that supply methadone, but it's under the banner of people who inject drugs, and also people who inject drugs get more funding for HIV prevention. And that for me is a massive legislative barrier, because that means the bulk of people that are using heroin and really need a substitution therapy can't access it. And I actually published a paper comparing the heroin cannabis smokers to the IV users. And very interestingly, I found that the treatment outcomes, so I followed them up over a period of time, and at 3 months and 9 months, actually treatment outcomes were very similar, and in a few domains, even worse for the heroin cannabis smokers. Yet this term, people who inject drugs, I suppose in a South African context, just, it doesn't work so well there. So I wanted to add that.
Yeah, that's a great point. I will say that here, we don't have so many smokers. Most people who use opioids do inject from the statistics that we have, but we do have people who will take opioid drugs in tablet form. So like medications, often over time, they will transition to injection drug use, but smoking here is just not as common. Yeah, I don't really know why.
To add to what Nirvana is saying, in South Africa, although we've started off with the smoking population, some of our provinces, now the Western Cape, are transitioning to an injecting population because there haven't been treatments to address these smokers. Is there another question? Anyone else want to put up their hand? Anything else in the chat?
I don't see any questions particularly from anyone. Yeah, but yeah, you can just
Oh, there's a hand.
and raise your hand and ask a few questions.
Yeah, I'm Hari from Indonesia.
Yeah.
Francina, in your slide, the text of message is about many women also like have comorbidity about dual diagnosis, and in my country, in Indonesia, actually the number of people who using stimulants like methamphetamine is very high, and also women. And I think it's very it has like a connection between amphetamine use with like maybe a depression in women. And sometimes we also found that many like sex worker also use amphetamine, to be more like have energy. So what do you think about it?
Yes, we see that in this slide that I presented about prevalences, amphetamines were less represented because they are starting increasing in Spain in the last years, but we don't have a lot of methamphetamine and amphetamine use in our context. It's related usually to the men who have sex with male in chemsex parties, and we don't see a lot of women using methamphetamine. We are starting seeing this, and the main problems we see with methamphetamines are psychotic problems, psychotic symptoms, sometimes also somatic problems as cardiological problems and myocardiopathy. And we think that in women, probably the estrogens are preventing to develop a psychosis, and probably the problem will be related with the development of depression and affective disorders. We also see this in cocaine. In cocaine, the most prevalent comorbid problems are depression, more than psychosis, and even in males. And the other suspicion we have when we are studying depression in primary depression and induced depression, or hypothesis is that depression, the mechanism in the development of depression is different. For primary depression without substance use disorder, the neurobiological systems involved probably will be different. Serotonin is involved in primary depression without use of substance use disorder, but probably in depression that appeared after the use of substances as cocaine or amphetamines, we suspect that dopamine or maybe BDNF or maybe endocannabinoid system will be involved in this depression, and probably also serotonin. But when we look at different levels of serotonin, tryptophan or kynurenins, the metabolist of tryptophan, we see different levels depending of the depression is primary or induced, or the substance is alcohol or cocaine. And we think that there is an aggression to the brain, but probably will be different in a different way, and the neurophysiopathology will be different. I hope I have answered your question. Thank you.
Harry, do you have any further questions, or you can engage with Francina?
The answer is enough.
Okay, thank you. Thank you, Francina.
Thank you.
Preeti, do you have time for any more questions, or should we move on to the next section? That's Roshan and Nirvana going to update us regarding.
As you say, I think we can have 5 more minutes if anyone has any questions.
5 more minutes. Okay, 5 minutes. Right.
I have a question for Beatrice. Beatrice, when you presented your study, you said that Malawian women are very conscious of whether or not other women are drinking, and are very conscious of what the social norm is around them. Do you think that influences underreporting in any way? Knowing what other women are doing and knowing what's normal for the women around you, does this mean you'll report less, that you're drinking less?
Thank you, Lisa, for that question. That's why I say the reporting could be affected, because sometimes we wonder if it's indeed just 1.6%, because in the cities, in the towns now, a lot of women are drinking, starting to drink over time. But because these are national level studies, I think this is more in the rural where a lot of women are not as open as others. There was another study that compared university students, females in university versus the general population, and they found that among the university students, this norm does not appear, like it does not explain the same, because I think for them, it's not so much who cares what you're doing. So it could be an effect of population level studies. Maybe if you could maybe do sub-analysis for different contexts, maybe it will be different. Yeah.
Thanks.
So just to share how I managed to get as many, like, because if you see the prevalence of alcohol use disorders within my study was significantly high. Of course, these are people that are sick in one way or another. It could be because they're drinking or not, but it was not going to be easy to get people to report and say, yes, I drink. So the way the audit was modified is not to say, because the literal meaning for how much do you drink, like, is something that can be predictive. I mean, can be restrictive for people to respond. So we're saying, so in literal translation would be, do you test alcohol? Do you, like, have you ever tested it? So from there, because they're thinking, oh, you just test, yeah, I just test it once a week. So some people say, oh, I test it once a week, every week I do. But if you say, do you drink? They would rather not say that they drink. I hope I'm getting clear. Yeah.
Can I have ask one more question to Beatrice? I really enjoyed seeing your study as well. And I think I saw in your background that you've also done some work regarding the role of the alcohol industry and policies regarding the role of alcohol industry in Africa and well, specifically in Malawi. It's also something that really angers me, the impact that they're having. And with regards to what you just mentioned, the rising rates of female drinkers in cities, would you say that that's a contributing factor because of the alcohol industry? Because I think what we do see is the alcohol industry using alcohol as a synonym for women empowerment, and using the advertising to make women feel like this is a feminist thing. This means that you're empowered and you're liberated. And is that something that you're seeing or recognized as a factor for the rising rates of women drinking in Malawi?
So thanks, Nirvana. I would say subjectively, without having a specific study on that, there's been a lot, and I mean a lot, of marketing efforts. If you see the audit diagrams that I had in 2017, now I would have to change it a lot, because even the pictures, even the way the branding has changed a lot to make it look femalish. Like recently, there's one national brand called Kuche Kuche has been moving, and they had the green version, and now they have a black version. They keep changing the versions, and they're more attractive. So there are females that feel like if they go to a party and they're not holding such a bottle, then they are wayward or they're backward. So I think one thing that not only Malawi, but I believe most countries are struggling with is how to control the marketing. It's not easy. Yeah.
Thank you.
Yes, I think it's not only the females, but also the adolescents, the youths they are targeting. These are the two main targets of the alcohol industry nowadays.
Sure. Because they know males already drink, and they are not the target. The target are the females and the young people. Yeah.
Okay, Preeti?
So,
Is it time? So.
yes. Thank you to the chairpersons and the speakers. I would now like to request our dynamic chairperson of ISAM-NExT, Dr. Rosenberg, to give his updates about our committee.
Regarding webinar, I think I really enjoyed this webinar, and it was a really excellent presentation from all the speakers. Francina first covered all the aspects related to gender, including the biological aspects, and she made a case for the research, training, and separate clinical services, gender-sensitive services, which I totally agree. And I think it's a huge learning for all of us that we should focus on specialty clinic or woman-sensitive clinics in our settings. Then Amanda has covered her views from and her research from the Asian countries, Central Asian countries, and she also told about the case about methadone maintenance program there and how this is affected by the neighboring country policies and things. So it's a very really interesting to know about this region, which is not much talk about, and it also gives us message that we should have country specific policies rather than depending upon the other countries and other region, because this is diverse. The addiction problem is diverse, and this seminar is this webinar is telling about us about the diversity. So as much as diverse it could get, Beatrice has given us perspective about alcohol problem in Malawi, and she has also presented her research. Thank you for your presentation, all of us. And I would like to update about the ISAM-NExT, that this webinar series which we have started about 2 years back. This is about 5th joint webinar together, and I like to thank particularly Nirvana for her constant support for this. Without her support and without joint collaboration, this could not have been done. We have line of activities coming this year also. We'll be having ISAM conference in Morocco, November. So I would like to invite all of you to join us in Morocco. And there is a still deadline to there to present, submit a symposium and free paper. It's a 30th April. So if you are interested, then you can you can still submit or just get back to me. I'll facilitate. Even if the deadline is over, we can actually stretch for some time. And I hope that we'll continue this collaboration, even if there is a change in leadership or new people coming. We have already younger people and dynamic people like Amanda coming up. So we'll have the hope this collaboration continues. Over to you, Nirvana.
Thank you so much. Yeah, thank you to the organizing committee. Preeti, you're excellent as usual organizing skills. Thank you, Lisa, Abhishek, and our wonderful speakers, Francina, Amanda, and Beatrice. I really enjoyed this, and I think what Roshan mentioned about hearing perspectives from countries that we don't always get to hear about, that was just so rich for me. I really appreciated your presentation, so thank you very much. And yes, of course, we from NECPAM, want to continue this webinar series. I think it also gives us as, an opportunity to just participate and give people a chance to present their work, which in a platform that maybe for some feels less intimidating. And yeah, I think it's a great peer education exercise. In terms of updates, so I think the first update from Roshan's, what he just mentioned, is the NECPAM election that's currently underway. So we in the process now of having nominations open. And so by early June, we should be announcing the new NECPAM board. And of course, with our collaborations, there will be a handover period where I will still be chair. There will be an acting chair. So Roshan, we will keep in touch regarding all of that. And then in terms of activities that we participated in the second half of last year, quite a few NECPAM members were at Lisbon Addictions. I think we mentioned that in the last webinar, but just to give you feedback that NECPAM, we actively participated in a backcasting exercise on digital interventions for addictive disorders. It was a very interesting experience and is now under peer review. A publication should be coming out of that. And to mention that the WHO ADAB forum is coming up from the 27th to the 30th of June this year, and NECPAM will be present there, and it gives us I think early career addiction medicine professionals a nice like representation in a forum like that. So if there's any points that we want to bring up specifically as early careers, please speak to myself or anybody, and that we can take that to a big forum level in Geneva. And there was one other thing. NECPAM was also invited in January of this year to the World Health Organization in Geneva. I went as a representative of NECPAM to the Global Alcohol Action Plan meeting, which was a fairly small meeting where we got to debate different things about the Global Alcohol Action Plan and propose ideas of how we as networks and organizations can disseminate the information and ensure an effective implementation of the revised Global Alcohol Action Plan. One of the things that I had mentioned is that we would like to, as NECPAM or early career networks, teach our members about the action plan, just inform, so that at country level there is some transfer of information. So perhaps for the next webinar we can think about that as a topic. And yeah, it was lovely to be on this with all of you and to see some people that I haven't seen in a while. Thank you.
Thank you.
Thank you, Dr. Nirvana, and thank you, Dr. Rosen. So we are nearing the end of the webinar, and I would like to thank each and every one of you who have joined here. So there are certain people whom I would like to thank specifically. One is definitely the chairs of ISAM-NExT, as well as the chair of chair of NECPAM, Dr. Nirvana and Dr. Rosen, who had been very supportive from the beginning for this webinar. And without their initiative, without their leadership, the continuation of this webinar once every 6 months could not have happened. And I would like to thank Dr. Abhishek Ghosh and Dr. Lisa Danet for agreeing to chair this session. And I would like to thank the speakers, Dr. Francina, Dr. Amanda, and Dr. Beatrice, who had given their valuable time in this difficult topic. Like gender and diversity is a topic which is very intriguing, and at the same time it is complex and it is difficult to understand. They have brought in all those complexities in a very simple manner, and it was very wonderful, and it was intriguing and interesting to and for the audience to hear to that. And I would also like to thank Dr. RS from ISAM-NExT, who had actually prepared a flyer for this, and also all the ISAM-NExT members and NECPAM members who are actively working in this field to bring the field of addiction medicine ahead, and they are actively collaborating to move ahead in this field. So I thank each and every one of you. And last but not the least, Dr. Beatrice from the Gender and Diversity Subcommittee of ISAM-NExT is planning a survey to understand the to understand about the difference in the gender and diversity issues related to organization. So she has sent a link in the chat. I will also be mailing the link to all the participants of this webinar. So if you could contribute to this, it would be of great help to understand further about the gender and diversity issues, not only in the addiction field, but also in the organization level. So with this, I would like to conclude today's webinar. I thank you all.
Thank you. Bye, everybody.
Thank you. Thank you very much, Priti. Thank you, everyone.
Thank you,
very
Lisa.
much.
Thank